So, like Andy said, I am a very big fan of ultrasound, and that's my objective today. I'm going to convince you, not really only in cardiac arrest, but really in any resuscitative case, we should be using ultrasound. And I can imagine some of you are wondering why I put this picture up. First and foremost, just to show you how ridiculous you look when you're using your stethoscope. You can even, if you even look at that patient, he doesn't even seem that confident in what they're doing. Even the patient doesn't look great. And what's even worse, not only do they look ridiculous, they don't even let their own colleague use their stethoscope. So they're obviously discriminating. They look ridiculous, and the patient doesn't seem all that confident. So what can we do? So my argument is we can do the Lord's work. Look how happy Jesus looks when I'm ultrasounding. Look how happy he is. That's all he wants us to do is ultrasound. So this is going to be the topic today. What we're going to look at is ultrasound in cardiac arrest. So let me set the stage for you. This is a night shift. We're down in Camden, North Philly, even downtown. And a patient comes in. You hear overhead that there's a 70-year-old male, end-stage renal, cancer, COPD, CAD, hepatitis, pretty much your typical patient that would come in. And then what's even more typical is your EMS arrives. And what you see is just, incredible CPR happening. This is what happens in North Philly. I'm sure it happens everywhere else. And you get that incredible story of all that past medical history, and it was a witness collapse. So I know what everybody's thinking. They're going to jump on the chest, continue CPR, maybe some epinephrine. You also even heard that there was end-stage renal, so maybe a little calcium, bicarb. You're thinking maybe this is hyperkalemia. A couple minutes go by, it's time for a pulse check, which is where your first mistake happens. So you're sending either the med student or the intern diving in there, and you're going to try to find a pulse. The study that I found, at least where we're the best at it, is 78% of the time we can accurately determine if there's a pulse or if there's not a pulse. 78% of the time. Some of the other studies show that not even 50% of the time are we accurate. So you pretty much can just flip a coin whether or not they have a pulse. And especially on someone like him, I don't want to go looking for it. So what do? First and foremost, you can try your vascular probe. Hopefully these will play. But you can try your vascular probe, and this will actually determine whether or not you actually have a rhythm right now, or a pulse at least. My argument is, when you're using ultrasound, try to simplify it. So you don't want to be switching between probes. So really stick with a cardiac probe, because that's really what's going to help guide your resuscitation. So aside from just looking for a pulse this way, switch to your cardiac probe and see if they actually have a rhythm. It's much more accurate when you can actually visualize what's going on as opposed to just trying to palpate and guess what's going on. So use your ultrasound in your initial evaluation of the patient to determine if there's cardiac activity, if there's not. So you stop, you check for a pulse, you look at the rhythm strip. Who thinks this is asystole? Who thinks this is VFib? Anybody asystole? Raise their hand. All right, we got a couple people. VFib, got a couple more people. So there's some people, there's debate here. Which is it? I'm uncertain because, if this is asystole or fine VFib, you're going to treat these very, very differently. So asystole is what I initially thought, and this is what our typical teaching is. Think about the H's and T's. Think about these immediately reversible causes. But my argument for ultrasound is you throw it on the chest, and what if this is what you see? Your H's and T's aren't really going to help you there, and you're going to treat this patient very differently as opposed to just CPR, epinephrine. This person needs to be shocked. This is fine VFib. This is a pretty easy case as far as knowing what to do. I think the majority of the focus is going to be PEA and asystole and how ultrasound is going to help alternate your therapy. Certainly in this case, it's very important because you're going to shock this patient as opposed to just continued CPR and epinephrine and other treatments depending on what your differential is. So contrast that image to this. I don't know how well these are showing up, but basically this is asystole. There is nothing going on here. And again, asystole compared to VFib arrest, you're going to treat these very differently. And we really wouldn't know just feeling for a pulse or looking at the rhythm strip how to differentiate these individuals. And ultrasound's really the way you're going to go. just a side-by-side comparison, you can see kind of not that easily to differentiate, but the one on the right here is obviously asystole, and then the left, you can see that fine V-fib. So again, it's just the importance of knowing what you're going to do and having a more goal-directed treatment. Contrast this with this image, and hopefully it'll play. All right, so some of these I apologize that aren't playing, but this is tamponade. So this is a very different situation that can present very similar. This individual had end-stage renal, had cancer. He's the type of person that definitely would develop an effusion, and cancer patients and infectious disease are most likely to develop tamponade. So in this case, you know, if we could identify this earlier, we can intervene immediately as opposed to continued CPR, epinephrine, our traditional management. This is a case where you can easily intervene right away. The last one I want to show you is this one. This is kind of a very different case, and I'm going to introduce kind of a topic that's had recent press. This is a case where you can obviously see it's a very, very poor EF, so much so that they're really not generating a pulse pressure. And this is something that we've come across commonly. And what should we do in this case? So these two different terms were introduced, prem and press. There's pulseless rhythm, echo motion, pulseless rhythm, echo standstill. And this echo standstill, or the press, is what traditionally is described as your true PEA, your true asystole, as opposed to prem is when you actually have cardiac activity. And this is what not me, but others have termed pseudo-PEA. And you want to treat these individuals like profound shock. You want to have your central access. You want to put your A line in. You want to aggressively resuscitate them if they need fluids or if they need pressors. And obviously, push-dose pressors as opposed to co-dose are much more appropriate and beneficial to this patient. So again, prem and press are important things to identify, especially when you see just a very poor EF on your code patients coming in. So let's take a look if this will play. So here you can see obvious organized cardiac activity, but almost no EF. So this person most likely won't be generating a pulse that you can feel, but they certainly have cardiac activity. And these are the cases that we need to be aggressive. We need to place the A line. We need to think about push-dose pressors. We compare that to this case, and fortunately this one's not working anyway, but it's cardiac standstill, which will show either way that nothing's happening. When we look at these individuals, we want to also take a look at what their QRS is doing. And I'm going to briefly touch on this because obviously this is a cardiac or an ultrasound talk. But quickly incorporate what your rhythm strip is showing in addition to your ultrasound, because that's also going to kind of guide you there, whether it's a wide or narrow. Wide, we think about hyperkalemia, we think about tox. Narrow, we're going to think about our more traditional types of causes that ultrasound will help us identify. Cardiac tamponade, tension pneumo, PE. We talked about, you heard a lot of the different findings in PE before. I think the most important ones for us in a code situation are a dilated RV. The other thing you can think about is looking at a DVT. It's a quick study. It's out of the way of chest compressions. Think about that if the person's at risk for PE, and add a DVT study. Very quickly, looking in the femorals, looking in the pop. You can do that out of the way of actually ongoing CPR. And if they have a DVT and it was a witness collapse, they were complaining of chest pain, shortness of breath, these are the individuals that may benefit from TPA. And just a quick example of what our clots would look like on ultrasound. All right, we'll skip that since we kind of went over that for the most part. So does any of this make a difference? I think that's the biggest question. Does ultrasound make a difference in our cardiac arrest patients? So this was a study, single center, several years ago. Mike Blavis and Dr. Fox out of California now, that looked at ultrasound in cardiac arrest. And what they found was that if these patients had cardiac standstill on ultrasound, none of them survived. So the argument could be made, because we put a lot of effort, time, resources, energy into resuscitating individuals. The individuals that come in with cardiac standstill, we may need to start rethinking how aggressively we're going to resuscitate them, because we're really not seeing positive outcomes when they come in without any cardiac activity. More recently, we look at the Reason trial, 20 US and Canadian sites, multi-centered, and they were looking at out-of-hospital cardiac arrest or in the ED. And they were basically focused on PEA and asystole. And they included about 793 individuals. We won't go too much more into the details of it, but what they saw was that nearly a third of the patients that were initially thought to be in asystole or PEA without cardiac activity actually had cardiac activity on ultrasound. And then what did they see? So of those individuals that had cardiac activity, 51% actually had return of spontaneous circulation. That's as opposed to 14% that did not have cardiac activity. Unfortunately, there's not a huge difference as far as outcome. About 4% of the ones with cardiac activity survived to hospital discharge, as opposed to less than 1% without cardiac activity. The one problem with the study was this wasn't patient-centered. We have no idea what the neurologic outcome is. And I think probably the most important thing to take from this is some of the most immediately reversible type of causes of cardiac arrest, like the PEs, like the tamponades, are reversible. And then otherwise, we may start to consider that some of these individuals without cardiac arrest, especially advanced age, that we may need to terminate resuscitative efforts and kind of direct our energies, especially in the emergency department, to our other patients. So a couple subsets of patients. So PE, I will not talk too much about PE since we already went over a lot of RV findings earlier. But again, in cardiac arrest, think about RV strain, look for a big dilated RV, consider a DVT study. And what we're seeing here is this subset of populations in this trial, 15 of them actually had massive PE, and almost 6% of them survived after receiving TPA. So these are the patients that we can make a difference as far as the immediately reversible causes. Another study, this was a single center though, retrospective, but does show promise with half-dose TPA, looking at survival. 20 of 23 patients with PE actually survived with good outcome at 22 months. So these are, again, the individuals that we're thinking that we can actually intervene on and in a positive way, and ultrasound is going to be how we identify those. Last thing I'm going to mention is whenever ultrasound comes out with something really cool, somebody's got to hate on it. So we look at this study. So again, single center, limited numbers, only 23 patients. But what they found was with the addition of ultrasound during cardiac arrest, their time off the chest went to 21 seconds. Their baseline was 13 off the chest without ultrasound. So, you know, they're suggesting that there's limitations with ultrasound, and obviously there are, and we actually looked at this at Temple. I don't want to share our numbers because they weren't much better as far as time off the chest. So how are we going to do this? How are we going to improve with our time off the chest with ultrasound? So these are the individuals. You don't want your fourth-year med student or the intern just learning about ultrasound. You want your most experienced person in the room with ultrasound on the chest. You want to find an area where the best view is, whether it's subxiphoid, your apical 4, try to be out of the way and take clips, just hit retrospective clips. So get your clips, make sure someone's counting 10 seconds, and then get off the chest. And then once they're right back on, we look at the images and guide our treatment that way. Because, I can understand, even watching my residents and myself, you can kind of get distracted trying to find the perfect image and whatnot. So again, the most experienced person, you want to find the best area, mostly off where they're actually performing, so subxiphoid, apical 4 chamber, and take clips and then review during that time that they're back on the chest. And lastly, we won't go too much into this, is TE. This is something we just started looking at Temple, and a study just came out of Canada. And this is actually something reasonable that we can do in the emergency departments. And what they're showing is there is actually a much greater time improved off chest because you don't need it. It's placed there during cardiac resuscitative efforts, and you have no time off the chest looking at rhythms. And what's even more important is that it can actually help in your CPR as far as guiding placement and depth of compression. So, as this becomes much more feasible in the emergency department, this is maybe something that you guys are going to be seeing in the future as TEE. So lastly, ultrasound-guided resuscitations, not just in cardiac arrest, but in any unstable, hypotensive individual. Think about prem and press, look for cardiac activity, and treat what you see as cardiac activity as extreme shock. Look at the rhythm strip, whether it's narrow or wide. Take clips, have your most experienced person doing it, and think about ultrasound guided procedures when you're putting the A-line in and whatnot. And that is it.